CataractCoach.com, podcast series, episode number 80, with Professor Shady Awwad, Success with Complex Refractive Surgery Cases. Welcome back to our Cataract Coach podcast, and today I have a very special guest, my dear friend, Dr. Shady Awwad from Beirut, Lebanon. You have an incredible expertise in everything cornea, and I have learned from you in so many different countries all about the cornea. So I'm so excited to talk to you today. Welcome to our podcast, my friend.
Thank you, Uday. Thanks a lot. And it's always an honor actually to be on this podcast. I've been following you since the early days. I've been always impressed by what you're doing, and I learned so much from you. And it's an honor for me to be on this podcast again. Thank you.
Yeah, I finally remember right before COVID, maybe 6 months prior, you invited me to come to your conference there. And we had a great time. And what I was most impressed about is I got a tour of your clinic and the amount of corneal expertise. How did you learn so much about such a little piece of tissue?
Well, it's hilarious, but I did ophthalmology because I wanted to be a refractive surgeon. That's why. So I loved ophthalmology, but the main reason I did ophthalmology because I wanted to do refractive surgery. The optics, the physics, both on the cornea and the lens and the whole optical system is what actually, impressed me when I just first got in touch with this specialty.
Yeah, so you have a lot of expertise in so many different aspects of, let's say, refractive surgery, but especially in the cornea. So now, years ago, when we first started ophthalmology, everyone thought of refractive surgery as like cornea-based. And no one imagined that it's obviously going to encompass everything. So now refractive surgery means cornea, lens, phakic IOLs, regular IOLs, everything in between.
This is so true. And that's why I'm one of the champions of refractive surgery as a specialty by itself. Because, I did cornea refractive in Dallas and UT Southwestern. And I think just like any other cornea/refractive, you get a lot of cornea. And then the refractive, you just get to know how to do the procedure. And you have limited time to really understand it, understand the technology behind it, because you're busy fixing corneas and doing transplants and following corneal ulcers. I mean, cornea is demanding as a specialty itself. But refractive surgery is different. It's about thinking. It's about really looking at the technology, at the physics, and as well as the application. And that's why when I returned back to the American University of Beirut, and many years later, I decided to have a fellowship purely in refractive surgery. So the fellow has protected time. She or he doesn't feel that they have to deal with cornea and then in their spare time deal with the refractive surgery. They have the whole time focused on the refractive surgery.
Right. So at UT Southwestern and Parkland Hospital, boy, you worked hard. That is a very busy place.
It is.
And then I can imagine you did a ton of corneal trauma, corneal ulcers, perforation. You had like so much cornea, but maybe not as much refractive.
This is so true. However, we had a lot of exposure to refractive, but because I was interested in refractive, I really forced my way there. But if somebody is not really interested in refractive or maybe equally interested, you might fall into the trap, just like any other fellowship, to deal with a lot of cornea. At the same time, deal with refractive, but not as much. And I think that's not just in UT Southwest, it's everywhere. Whenever you have cornea/refractive, the cornea predominates over the refractive aspect. So that's why I always, I thought that there should be a fellowship purely dedicated for refractive, where you think both on the cornea, on the lens, as you said, everything now is, needs some refractive surgery understanding in order to better perform, whether you're cataract surgery, whether you're corneal surgery, or any other aspect.
So your refractive surgery fellowship is then everything. It's corneal based, it's phakic lenses, it's IOL cataract surgery, it's everything.
And it has also therapeutic refractive surgery, because I think this is something, again, that has more and more taken over the world, but not in every aspect. I'm sure in the US is still lagging because of a lot of constraints by the FDA, but therapeutic refractive surgery, dealing with the keratoconic eye, rehabilitating the keratoconic cornea without really needing a corneal transplant. There are so much we can do now. The technology has evolved so much that in our practice, getting to a corneal transplant is now a rarity in keratoconus management.
Yeah, that's changed a lot because I remember 25 years ago when I was a resident, the treatment for keratoconus was you put them in hard contact lenses until they can't tolerate it, and then you do full thickness penetrating keratoplasty.
Exactly.
But now it's different. Now what's our treatment regimen? What's the pathway?
So I think the first thing that actually made things possible is cross-linking. It is true that cross-linking basically stabilizes the disease, but actually the advent of cross-linking allowed us to start doing topography-guided PRK and surface ablation on the cornea, and then whether doing cross-linking first and then doing the topography-guided, or whether combining them together. But that has opened the door to a new modality of treatment. Then came along the corneal ring segments, which were already present before, but corneal ring segments used to only improve the vision and the quality, but not really stabilize it. So now with the combination of the two, you can debulk the aberrations using an additive technology. Before it used to be corneal ring segments, now it's corneal allogenic ring segments, so it's also
Right.
have much better control of the cornea with minimal side effects. And then later, cross-link the cornea, reshape it, fine-tune this big cone that has now improved, fine-tuning with a little bit of shaving. I always stress that we should not really target lower order aberration. We spare tissue as much as possible by treating the higher order aberration. And this way, by performing a corneal ring segments, debulking the aberration, fine-tuning the aberration with topography or corneal wavefront guided technology with cross-linking, and finally, and if the patient is really having an anisometropia of any kind, we can still implant a phakic lens in there, what we call sometimes the quadruple procedure. So KS or corneal ring segments, cross-linking with topography-guided PRK, and that's 3, and then the 4th would be in a phakic lens in there. So quadruple procedure for the ultimate improvement.
That makes a lot of sense. So yeah, interesting that you say you don't want to take away too much corneal tissue by treating the lower order aberrations like myopia.
Exactly.
You can use the phakic lens for that. When you take away any corneal tissue, just do a little bit to treat the higher order aberrations.
I fully agree. I always say you can outsource. So stromal tissue is precious, and what we need to do is just leave it for the fine-tuning of higher order aberration. Instead, outsource your bulky higher orders to the corneal ring segments or the KARES. That's additive. Outsource your lower order aberration to either phakic lenses or spectacles or soft contact lenses, and leave everything else for the excimer laser fine-tuning. And that's by this way we could really minimize tissue ablation.
So really prioritize saving that precious corneal tissue. Don't just keep ablating it away.
Exactly.
Oh,
That's why, again, first, I really give big credits to the Athens Protocol, because Athens Protocol came in 2006. 2007, Kanelopoulos published his series, and then Kimionis as well. And we had a follow-up of 10 years, and that's great. But the Athens Protocol at the time used to plan is 5.5 millimeter treatment. Treat the higher order, but treat also 40% of the spherical equivalent and 70% of the astigmatism. So basically that's good, but that's again removing tissue and downsizing to a 5.5. Now with the technology that we have, we can really go all the way to 6.5 or 7 millimeter optical zone, focus more on the lower order aberration and almost not touching anything extra. And this is important today, because what I mean is, if you treat coma, you're going to treat some of the astigmatism embedded into this coma.
right.
If you're going to a spherical aberration, there is some myopia or hyperopia embedded into it. So I'm not saying do not treat at all the lower order, but we need to treat what's embedded into the higher order aberrations. So if you have a certain plan for your higher order aberration, that plan might end up treating 1 diopter of astigmatism and 2 diopters of CE. Perfect. Just stick to that and don't ablate more, because the more you're going to ablate, the more tissue you're going to remove.
So what's the order you'll do this in then? You'll put in the allogenic ring segments first?
Correct.
Then stabilize, then cross-link, then do your ablation, excimer laser ablation, and then phakic lens?
So what I do typically is the following. I start with the case corneal allogenic segments. I follow up the patients over 2 to 3 months. I see how they're doing. And then the next plan, if they improve, dramatically, and the cornea is pretty good. The maybe the aberrations are minimal. I only cross-link, and maybe I might do later wavefront guided or topography guided, maybe not. However, if the improvement is not sufficient yet, if I see that there is room for further improvement, I actually combine the cross-linking with the topography guided or the corneal wavefront guided PRK. Before, this approach, this simultaneous approach, used to be very controversial, because people used to think that this causes haze and you should not combine them together. We have debunked this myth in 2 papers. The first one was published in 2021 in the Journal of Refractive Surgery, and actually it's received the Waring Medal for the best paper published at the time. Yeah, and then we actually, what we did, we showed that combining mitomycin C with cross-linking by itself causes severe haze. So the issue was that we were combining cross-linking at the time, Dresden protocol, so high energy, together with PRK, topography guide PRK, but not just that, with mitomycin C. Mitomycin C wipes out keratocytes down to 300 microns. At the same time, cross-linking wipes out keratocytes, especially the Dresden protocol, all the way down to 300 microns. The combination of these two will induce a massive keratocyte dropout, then a massive cytokines release, and then you will have a massive myofibroblast coming in and producing all that haze. If you just eliminate mitomycin C, and now with the accelerated cross-linking protocol, which end up really delivering much less energy, so we're seeing not much of that haze. And the next thing is, interestingly, now that we just published now out online this month, in September, in the Journal of Refractive Surgery, our prospective study where we used cross-linking with corneal wavefront guided or ocular wavefront guided PRK, but without mitomycin C, and compared it to cross-linking alone. And we looked at haze based on an analytical software that we developed. It's a machine learning software. We have a patent for it. And we saw that there is no difference in haze between the two groups. So really the culprit is mitomycin C.
And that's so crazy, because we always thought that, look, mitomycin C is going to prevent the haze, but it's not.
Exactly. Because there are 2 big insults here. And then if you just use it on alone, so the message is, if you've done cross-linking before, and now you're revisiting the cornea with topography guided or corneal wavefront guided, then that's fine. You definitely have to use mitomycin C. But if you combine them together, if you're doing both procedure at the same time, then there's too much insult, and that's the issue. So best is actually to omit mitomycin C, because cross-linking is wiping out the keratocyte anyway, so we don't really need the mitomycin C when we combine them together.
Wow, that makes now that you say it like this, it makes a lot of sense, but I would have never guessed that.
Yeah.
I would have never guessed that mitomycin C in this case was the culprit behind why you got the corneal haze. So interesting. Now, when you do the corneal allogenic ring segments, what's the nomogram? I'm not a cornea guy, so I got to learn from you. And how do you determine how much of a ring, how much of a segment, how big, how do you figure this out? Is there a nomogram?
Actually, we published our nomogram. It's an initial nomogram in the Journal of Refractive Surgery about 1.5 years ago. There is also another nomogram by Alan Schlick if you're using CataractCoach. But our nomogram was actually derived from the corneal ring segments, the PMMA nomogram, because we looked at the way they both interact with the cornea, both on the stromal and epithelial level. And we actually found that they're almost similar in terms of action. One is hard, one is soft. But if you squish a soft allogenic segment into a tight tunnel, it's going to act almost like a hard structure. And then we found out that all what we have to do, the thinking is the same. We have to just hug the cone, focus on the coma. The thinking was exactly the same. All we have to do is to change the thicknesses. So for instance, if you're using a 450 micron for the PMMA segment, here you're finding a 750 on the allogenic segment, and the 750 gets squished in the cornea for about 450. Exactly. And because the depth is different, because the PMMA, you implant them at a deep 400 microns depth. However, the allogenic is actually between 250 and 300. So all what we have to do for over 2 years, from 2019 to 2021, is figure out first, which thickness corresponds to which thickness in the PMMA value. And then after that, from 2021, we just shifted completely to the allogenic segments because we felt that we are now confident enough to move to moderate keratoconus and even milder form. And we know that we're going to get similar to the PMMA and even better, especially in advanced forms.
Wow. Okay. It's so interesting how it's evolved over time, because I'm old enough to remember back in the late 1990s where the intrastromal ring segments were made of PMMA, polymethyl methacrylate, were actually marketed as the treatment for low myopia. They were called intacts, and you put in 2 ring segments to form a complete ring, 2 let's say hemicircles, and that was for treatment of like -2, 3, 4 of myopia.
It's so true. And we all owe it to the late Professor Collin from France, who basically first used them in keratoconus. And it was a major paradigm shift ever since. Yeah.
Right. It just completely changed the way that we treat that disease. It's so interesting. Now, let's talk about in keratoconus. I think a lot has been talked about eye rubbing. What's the correlation here? Now, I'm so afraid of all these meetings. I don't want to rub my eyes ever. I'm so afraid.
You know,
It's a direct correlation.
Yeah, Uday, I think I truly subscribe to the opinion of Damien Gatinel. I mean, Damien Gatinel maybe takes it extreme because he wants to make a point, okay? But I do believe that a lot of it is true. So basically, I think if you have a genetic predisposition, and we still, it's a controversy whether really there are genes but if you have genetic predisposition and you don't rub your eyes, you will never get it. But if you do rub your eyes, even if your eye is normal, you will get it, but at a different level. So I'm going to give you an example. In about 7 years ago, we published in the American Journal of Ophthalmology, we looked at the first degree relatives of keratoconus patients. So if a kid, his parents or her parents and sisters, a parent, their daughters and sons, and then we looked at what were the prevalence. And then we discovered that even though overall about 80% had keratoconus to start with, but many of them had thin corneas or high astigmatic cornea, but didn't have at all keratoconus, which is interesting because it tells you that the genes, maybe there are some genes for thinner corneas or some genes for weaker corneas, you develop some astigmatism. But if you rub your eye, you have a higher tendency to develop keratoconus than if your eye is normal. Kind of the same concept if you have a white skin or a darker skin. A whiter skin, if a person goes out in the sun and suntans every day, then the chance of developing a squamous cell carcinoma will be much higher than a person with a darker skin doing exactly the same activity. Sure. So I do believe, and interestingly, I do believe another thing is actually sleeping on your face, because some patients would swear that they don't rub their eyes, and when I ask them, do you sleep on your eyes, on your face, they lie yes, and sometimes we sleep with our hands like that, exactly on the eye that has more keratoconus than the other. So that's another important thing for me to ask, and I actually takes it further enough. I tell my patient whenever I perform keratorefractive surgery, I tell them, I will do it on you if you promise me one thing. You won't rub your eyes anymore. It's a bit extreme, but I see that almost everybody coming with corneal ectasia, typically they rub their eyes. If you're doing a perfect topography and you look at your topography, it's fine, and the patient develops ectasia, it's almost always because they rub their eyes.
So a lot of post-LASIK ectasia is due to eye rubbing.
I agree. Unless, of course, if you miss the diagnosis from the start. But now with OCT technology, with Scheinfeld, with all that, and then with the awareness of keratoconus, rarely we do really start with bad tomography, but still every now and then we see ectasia. And if we ask these patients now, they almost all admit that they rub their eyes.
That's so interesting. Yeah, because we've seen those patients where the pre-op topography, tomography, dual Scheinfeld, everything's normal, looks great, very low treatment, ablation, -2, 3, 4. They had good thick corneas to begin with, and they end up with ectasia. It's like, how did the patient get ectasia? So do you think there's a strong correlation between the eye rubbing or sleeping on your face?
I do fully agree with that. And then again, once Damien Gatinel started with this concept, first I was a little bit skeptical, but then when I started really asking my patients and really I play the devil's advocate, and I'm subscribe to it. I think there's definitely an element that predisposes us for ectasia for sure, but rubbing the eye is what tips the balance.
Right. I saw the video that he put out, his group put out. It's like a video of like an MRI scan, live action, where the patient's rubbing the eyes, and the deformation of the globe is amazing. It was shocking.
And we think also of the possible retinal tears that people can get by doing that. I mean, that's possible.
Now I'm afraid to touch my eyes. Now let me switch gears and talk to you more about on the cornea with excimer ablation. What about presby LASIK? Now that really hasn't taken off a whole lot. Do you think there's a good role for presby LASIK or treating presbyopia in the cornea?
I think it's a very valid way, and I think before we used to be harsh on it and say that it's multifocal lens, but multifocal cornea. But actually, if really we subscribe to the pure spherical aberration induction, I mean, that's what we do with the EDOF lenses. And ideally, if we say that in the future these patients might get cataract, what are you gonna do? Actually, if the spherical aberration is still valid on the cornea, you can always implant a regular aspheric, not necessarily with a negative spherical aberration, but you could insert the lens that is corresponding to this cornea, even if you insert a regular lens. I'm going to give you an example. A lot of the hyperopic treatment that we do, we induce negative spherical aberration, correct?
Yes.
Some patients I've done 10 years before, and I've just done monovision at the time. But with this monovision, you have an induction of spherical aberration, about minus 0.1 per diopter of treatment, depending on your optical zone. So these patients, if you look at the 4 diopters treatment done, especially if you're aiming at the minus 1.5, for instance, that's going to give them a minus 0.4. And that's almost what we found in most of the EDOF for hyperopes. The EDOF varies, I mean, depending on the lens, but between minus 0.22 to minus 0.44, very roughly, depending if you're myopic or hyperopic. And then if you think about it, that's exactly what you're giving on the cornea. So those patients, when I go back and perform a regular lens and I put a minus 1.5 treatment, they're still very happy. They take much more than the target of a regular minus 1.5. So I think it's valid, but it depends how old the patient is. I think if a patient is 45, I'm not very enthusiastic to perform any kind of clear lens extraction,
Right.
especially if we know that the retinal detachment rate, correct me if I'm wrong, because you're the cataract guru, but I know from studies that I follow, 45, the mid-age people, 2% of them, if the retinal detachment is 0.2%, a study by Olsen, when they looked at all the retinal detachment, they found that it's almost 2% in patients who are middle-aged, because their vitreous is exactly at a time where it's tough, but not yet tough enough to pull on the retina and develop retinal tear. So this is exactly, however, the segment of patients who clearly are in between. Younger, you don't need it. Older, you go for a cataract surgery. So for these patients, I think this is a fair procedure, but we have to discuss with the patients. Ultimately, for me, I'll go and discuss with the patient what they might need in the future. And if somebody basically is an all or none person, I would just say, okay, no, I'm not going to do anything. And let's wait later, and then we'll decide when your cataract kicks in. But if somebody wants a solution now, they're young enough, I'd rather perform something around blended vision.
So like 45 to 55 years old, probably a good target. Once you hit 60, you're probably better moving towards an IOL solution.
Right. Exactly.
Yeah, I've seen that here in Los Angeles. Patients coming to me for a second opinion, young patients, let's say 49 years old, plano presbyope, and they went and had refractive lens exchange with trifocal lenses. They're miserable.
Exactly. These are the worst patients to deal with. I fully agree with that. And then again, if you think about it, even our IRI calculation are great, but never perfect. And we're dealing with patients who are demanding, who basically for FAR, they're still okay, even if they have plus half, but they're still okay for FAR. Whatever we're gonna do, they're gonna lose our confidence, their confidence in us if we start with a refractive error, because we know that especially in hyperopes, most of the IOL formulas don't fare better than 80%. So
Correct.
Between minus half diopter, that's something that we have to counsel our patients. Not all of them are ready for another refractive procedure as well. So we have to deal with these patients because their refractive error is so small that they think what you're gonna do them is going to be the final solution. They're not going to need another touch-up. They will take it as a uh, negative thing if you just tell them about another touch-up. If they have a +3, then it's different. They are already miserable, and then whatever you get them, they're happy. And you tell them, I'm going to fine-tune the procedure even further with a femtolacing. Then they're fine. They take it in a positive way. What do you think? I want to know your opinion about that.
No, for sure. Listen, if you start off with a higher hyperope, then they're already miserable. Like you said, if they're +3, +4, they're miserable for near and miserable for far. They'll love you. But you're right. Patients who are like close to plano presbyopes are the tough ones because their image quality. If you're a 50-year-old plano presbyope, or even like you said, a little bit of hyper, like +0.5, they still have fantastic distance vision, and their image quality is amazing. And so if you make them pseudo-phakic with a trifocal, you've actually degraded their image quality.
Exactly.
Yeah, you got to wait till they're 60 plus and they have some nuclear sclerosis and they have some decreased image quality. Yeah, that's my goal. Is I just have to make sure that the after vision that I give you after surgery is much better than the before vision.
Exactly. There are a couple of surgeons who actually perform also. They look at contrast sensitivity and see if the contrast is not that good, then they will proceed with trifocal. If the contrast is still good, they won't even perform clear lens extraction because they feel that the patient will lose image quality. So again, even if the patient has mild cataract, I mean, their contrast, if it's still okay, whatever you do, they're gonna feel the difference, and that's something important. Not all our patients need to also to know, and we need to know if what they value more or what they cherish is the quality versus functionality.
No, for sure, for sure. It's that before and after difference, the delta, how much delta there's. Like I would tell that when I used to teach residents a lot. I stopped 2 years ago, but when I was teaching residents, I'd say, the white cataract patient who has pre-op vision of hand motion, or maybe if you move your hand fast enough, wind perception vision, they can't even see the hand. If you end up with a sulcus lens and a little bit of anterior vitrectomy and a little bit of macular edema and 20/40 vision, they're going to love you. Exactly. But that patient who has the minimal cataract and you do their surgery, and again, like you said, the calcs are a little bit off, and you end up, with a refractive error even in a perfectly normal case, they're not going to be happy. It's the delta between before and after.
We always say patient's expectation minus patient results. The expectations.
That's a good way of putting it, for sure. If you can exceed their expectations, yeah. So I would say is like not only increase your results to get better and better outcomes, but temper their expectations, set appropriately reasonable expectations so you can exceed them.
So true.
Yeah, and then also you were talking about, with the younger patient, the vitreous is still in that kind of zone where it's maybe firmly attached to the retina. You get a patient who doesn't have a PVD, and if you take out the human crystalline lens, which is like 4 millimeters thick, you put in that thin IOL of only 1 millimeter thin, you collapse or capsular bag, the vitreous shifts forwards. You may not be doing them any favors.
I fully agree with that. And that's why I think this is a very critical age, and then we have to really, and then again, one thing is for presbyopia is that the natural lens is still kicking in. So the accommodation is still there. So whatever you give them, even in moderate monovision for them, for me is good because the rest is done by the lens, especially those early hyperopes where they're used. I always say that their spasm, their accommodative spasm is like a bodybuilding. Their muscles are still there. They can accommodate even in their late 50s. So this is still good. And why do I need to take away the crystalline lens at that age? If I can induce some moderate spherical aberration on the cornea, it's still possible. By the time they get to an age where they will develop a cataract or need a lens, probably the technology will be even better by then to basically accommodate all type of different corneal aberrations.
So what's your maximum treatment, let's say, for hyperopia in the cornea? With an excimer laser, you'll treat +1 or 2, okay, but where's your upper limit?
So it depends on the patient's age. If a patient is young, like a patient is coming at 20 years of age, of course, it all depends on the optical zone that I can have and also on the case. are the patient's case steep or not? Is the epithelium thick enough? Because we know that patients who have thin epithelium already, if the cornea steepens more, the epithelium will be thinner as well. But if we have good enough corneal curvature, we're not exceeding a certain limit. It's not written in stone that it's 48.5 or 45, but typically, if I can have a large optical zone at that cornea, I've treated all the way up to plus 5.5 or around that. And I know that basically a lot of doctors would shy away from that. But if you have the right corneal curvature, if you have a good epithelial thickness in the center, and you can really achieve large optical zone, and most importantly, if you have a latest generation laser, then you can do that. But however, if a patient is older, definitely not. I will not do that for many reasons, because number one, I think first, is it worth it to do that? What's the amount of aberration that I'm going to induce? And then soon enough, that patient might need a lens exchange or a cataract. So actually, my really target becomes maximum of about 3. So of course, with some monovision and extended depth of focus, maybe 4, but I would not go more than that.
Yeah, it makes sense. As they get older, a 20-year-old has such a beautiful crystalline lens with so much accommodation. So I get that. But then an older patient, you're 50 plus and you're a high hyperope, yeah, you're probably better off treating it in the IOL plane instead of treating it on the cornea. So that's a lot of steepening to ask for, right? You don't want to exceed a certain level.
Especially with them having dry eyes by now, MGDs and all that. I'm very careful, and usually anything, around up to 4 diopters. Again, the most important is for the surgeon to be very experienced with that. I mean, your limits, the aberration induced. You go for large optical zones. Your femto lasers, because you can get really a large flap on that, and I think you can do that. But more than that, I think it's pushing that button.
Now, what about on the minus side?
I think this is the trickiest part. I think this is the trickiest part. I definitely will never, I personally never perform clear lens extraction on a myope. That's for sure. So if a patient is within 45 to 55 or 60, I still perform some kind of a presbylasis, some kind of a monovision with some form of spherical aberration, or purely monovision as well. As long as we do the trial, we check with the patient, we ask if this is good for the patient. That's what I would do. I would just do that, and then later on, probably perform a cataract surgery at the time. But I would never do, at least personally, I would never do a clear lens exchange on a myope.
So how much excimer laser ablation would you do for myopia? Because remember, I remember when eximers first came out 25 years ago, more late 1990s. I saw my professors doing like -15, -16 of PRK and LASIK. I just tiny optical zones. I mean, that's obviously way too much. But how much myopia can we treat now? At what point do we say no more excimer? Let's do phakic lens.
So again, just right off the bat, if I have to give you a figure, but I'll tell you why there's nothing written in stone. It's about 8 diopters. More than 8 diopters, I'll shift completely to a phakic lens. But again, it all depends sometimes on the spherical aberration, the pre-existing spherical aberration of the patient, the corneal thickness, the amount of dryness the patient have, and so many other factors. But overall, the more we're inducing myopia, the more we're going to have spherical aberration, the more we're going to have dryness, and the more we're going to have risk for ectasia. So typically, around 8 diopters is roughly my limit to proceed directly to a phakic lens.
Yeah, I think recently, I mean, we've got a lot of uptick in the US for phakic IOLs. And I think the lowest we have here is maybe -3 or -4 for the phakic lenses. We still don't have lower than that, and we don't have plus power hyperopic lenses, phakic lenses in the US. But I think, yeah, you're right. -8 is somewhere in that range, depending on the patient, is probably your limit.
I think that with the introduction of the V4C, now it was introduced about a year and a half in the US, but we had this since 2010 or 2011. But that was a dramatic change in my practice, because I've seen bolts of 50 microns for many years, and then no cataract developing. All what I'm saying is that the chance of cataract is less because of better nutrition to the crystalline lens, because of that, or the chances of having acute angular closure glaucoma is much less because of that. It's not impossible, but it's much less. So it has made this lens even much safer. And then it's not anymore a major issue when you think about the lens. I mean, before, the connotation of cataract and glaucoma used to be, the main reason why we kind of shy away from it. But right now, this lens has become very, very safe, and it's a great alternative.
Yeah, I had a patient just yesterday that had cataract surgery on, and I did his phakic IOL 20 years ago, and I looked at him like, oh, that was back in the day we did peripheral iridotomies even.
Wow.
And so then yesterday I did his cataract surgery, which obviously removed the phakic lens and do the cataract surgery too at the same time. But yeah, you're right. I think it's improved a lot. Every iteration, every generation of these lenses gets better and better.
And the quality of vision is amazing. The quality of vision that you get with these lenses. I mean, even if you have some residual error, the patient gets still to see 20/20 easily, if not 20/15, while the same error in an excimer laser is not as forgiving. If you think about those lenses drop in half diopter already. So you might think they're not as accurate as excimer. Correct. But interestingly, because you're not much inducing any kind of major aberrations within at least a 6 mm optical zone, it is more forgiving. The patient still gets really great vision. So that's why I love those lenses.
Yeah, that's interesting.
Yeah.
Why does that make such a big difference, whether it's the treatment in the cornea or the phakic lens?
Because the cornea, we're inducing spherical aberration, and sometimes you might be inducing coma if the treatment is not very well decentered, it's not very well centered. So spherical aberration is already something, and coma, a little coma, is another. But these lenses have almost minimal induction, if any, of spherical aberration or coma within 6 mm. They're very forgiving. They're really large monofocal lenses, and I think that's why and then they sit closer to the nodal point. They're much closer to the nodal point than the corneal treatment. So definitely, if I have a plus half minus 3/4 of astigmatism, I mean, with excimer laser, that patient might be 20/25 to 20/20, but with the phakic lens, they might be 20/20 to 20/15 uncorrected. So
right. Despite the little bit of residual refractive error.
Exactly.
Yeah. Plus, I think we're seeing a big boom in the phakic lenses in a lot of upcoming markets, like Asian markets, because you don't have to buy a very expensive femtosecond laser, a very expensive excimer laser. You can all you need is a microscope in your hands.
This is so true. And then any surgeon experienced with cataract, I mean, the learning curve is very fast. While with excimer, you have to know your excimer, you have to know your nomogram, you have to plan for potential regression, you have to play around with your aberrations and understand them. So it's kind of it needs a lot of expertise. The ICL, if you're a great cataract surgeon, almost all residents they come out with good numbers. So that's the main surgery they train with. So this surgery becomes an easy transition for them.
Yeah, I think the only tough part for the US is just basically cost. Because if you compare it per eye basis, the cost for phakic lens is significantly what's more than doing LASIK.
Right.
Almost every practice, including mine, we charge significantly more per eye for a phakic lens than we do for LASIK.
Yeah, I same thing in my center, but I think in Asia, probably because they have a high number, they can really make it cheaper, I guess.
Yeah, I mean, maybe economy of scale. Yeah, no, makes a lot of sense. I mean, that's a neat procedure. It's kind of interesting now how we have such a spectrum of treatments available. So when you started off doing your training, I mean, refractive surgery is pretty limited.
Exactly.
And now it's like a whole spectrum of things.
I fully agree with what you say about spectrum, because we never try to put one technology versus the other. We have everything, and we tell the patient, you might be candidate for one better than the other, and somebody else will be candidate for another one better than yours. So it's nice that we can customize what's the best procedure for you as a patient, and that's nice. That gives us this malleability to fit all the every treatment to a different patient.
Right. But that's why I also think the surgeon's expertise is so important. When a patient comes to you, the problem we have so many good treatment options available. You don't want to give the patient a big list of like, here are the options. Which one do you want? Because the patient has no idea. You have to guide them into what you think is best.
I agree. I fully agree. Sometimes I like to let them know that there are other alternatives, but this is the best for them, for their specific case. Because if I don't tell them about any other alternative, they might shop around and somebody gives them something else and then they get confused. Why didn't I even offer them? So I kind of quickly go over all the possibility. When they get screened, they watch a video with all the possibilities from an ICL to a lenticle extraction to LASIK. They get kind of a quick primer on all these, and then later I just tell them, for your case, this is what I would suggest after discussing with you your lifestyle and everything. That's what I would suggest in your case, because ultimately I always tell them all procedures are great, but maybe there is a procedure that suits you better than another one.
Yeah, I think it's important to say it that way because the patient's coming to you for your expertise. I always think like, I went to med school, but let's say I need like a hip replacement. And if the orthopedic surgeon says to me, hey, for your hip replacement, do you want this model, the steel one, the ceramic one, the titanium one, I don't know. I don't know. I mean, guide me. I think, what do you think is best for me?
I fully agree, and that's why it's important not to let patients get confused with all these technologies available, or also that one is better, that one may be better than the other, and kind of get confused. I fully agree.
Now, let me ask you this too. In terms of refractive surgery, why is that market, at least in the US, seems kind of stagnant, hasn't really grown much? Like if you look at the last 20 years, cataract volume in the US has doubled, 2 million a year to now 4 million a year. But LASIK volume or keratofractive volume is kind of the same at about like 700,000 a year. It's kind of really not gone anywhere for 20 years. Why?
I think that's a great idea. I don't know. There are many marketers trying to understand, marketing companies trying to understand that. But I think, for me, I think one of the messages is that we should really get a unified message to the patient and not kind of confuse the patient with all these technologies and whether one is good, whether one is bad, or patients get confused and ultimately end up not doing anything. Just like in financial, sometimes like we say, we might do a a good decision or a bad decision, but the worst is not doing any decision. But sometimes because we are so inundated with financial advices that we don't do anything, and that's also bad. So I think we don't have a one message for the patient. For instance, I'm going to tell you something interesting. In one of the last congresses I've attended, they were pitting lenticle surgery versus femtolastic and saying which is the winner and dividing team. But if I, as a patient, Googling, and that's easy, I will get to that page and see, or some of the presenters are posting it on their LinkedIn account that, come up to that session. If the patient are going to see that the doctors are kind of confused and they're making this team against the other, then you know what? Maybe I'd rather stick to the contact lenses, because guess what? Contact lenses are not bad. So I'm going to stick to them and wait till they figure it out. So I think we're not sending the right message for the patient, whether lenticle surgeries versus femtolastic, whether this device versus the other device. And then what we really need to tell the patient is the truth, that actually all work great. And it's just, some variation between one and the other, but they all work great. We will select the best procedure for them, whether for this laser or another laser.
Yeah.
I think that's one of the reasons. I might not be aware of the others. Unfortunately, I don't know why 5% only of patients have had LASIK, or refractive surgery of any kind. And the 95% are just waiting because maybe they're confused.
I think you're right. I think it's confusion and then a little bit of fear thrown in, and then they just do nothing. Like, oh, I'll just stay out of it. Because if you look at other procedures, like it's interesting you said that, yeah, because I've seen similar things where they debate lenticular extraction of the cornea or versus femto LASIK, which one's better, why? If you look at like our colleagues in plastic surgery, I don't hear a debate about which neurotoxin or neuromodulator is better than the other. You don't ever hear that. You just go there and you're like, I want to get my wrinkle, and then you just go with it. You trust the surgeon.
That's true. Yeah, I agree.
Maybe our approach is wrong, because other aspects, not only in the US, certainly plastic surgery, injections, neuromodulators, fillers have gone incredibly high volumes. Even things like every kid in the US that turned 10, 12 years old, they get the braces on their teeth. But now, with more than 50% of the population being myopic, they're just sticking with glasses and contacts even when they're 20 years old, and they could be a great candidate for cataract surgery.
I agree with you, but I also agree that there's this thinking that they might still change, and then this way they're not sure when to do it. And I think that is another point where most of the patients, when they come in and ask, they keep asking how long is it going to hold. So I think if the minority who do get regression, or probably what I keep saying, it's actually progression, because some of us do change, but this is the minority. But if the minority is sending this message, while the majority, happy majority, are just happy, not sharing their input, we're going to end up with bad vibes about the procedure. And again, I think it's important for us to encourage our patient to share, whether they're happy or not happy, just to share, because then the majority will share their happy experience, while the minority will be really represented as what they are. If there's a 1% unsatisfied patients, I like to know that 1% is there, but the 99% need to voice their satisfaction as well.
Yeah, the problem is that we often get like the 99% of patients who are so happy share nothing, and the 1% who may be unhappy shares it everywhere. So it skews the perception of what is actually the reality.
That's true.
Yeah, I know it's an interesting thing. And then ophthalmologists too, I think we try to compete with each other for more of that 5% of patients who do refractive surgery, instead of going after the 95% of patients who would benefit from this.
So true.
Yeah, it's just kind of interesting to see this. I mean, I have high hopes that it's going to continue to grow and get that we'll get larger and larger, and we'll have more and more patients that we can help, especially as the world becomes more myopic because of all that near time on the phones, on the mobile devices. Yeah, it's just I guess time will tell.
Exactly.
Then now I'll give you a big challenge. How about this? I'm a -2 sphere. Oh my! And I'm at my age, in my 50s. This is like the best thing ever.
Yeah, I agree. I mean, again, that's
so like, what would you do for me? I'm a terrible candidate for anything then, right? What do you do for me?
I think the lower myopes are the worst candidates, because they're so happy with what they have. Whatever we're gonna give them, in exchange, is always gonna be the half empty part of the cup, not really the half full. So I think you're the worst candidate.
I know that. And then I've become so. You're talking about the muscles of accommodation. I become so lazy with those muscles because I just go without. I just enjoy the -2. So exactly. I don't even accommodate anymore.
Yeah.
So that's the tough one. Yeah, the patients like me come in and say, "No, my near vision's great. Just fix my distance vision." Exactly. And you're like, not so easy, buddy. Not so easy.
Yeah, and this is what I get often, like you said, like, don't worry about my near vision. I'm good. Just fix my far vision.
Yeah, I only wish we had something. And then I've even tried the monovision. Hate it. Don't like it at all. So just like this, I guess I'll stick with this until we finally develop that beautiful accommodating IOL that's coming, hopefully in the near future.
Yeah, that should be something.
Even that, I think the neat part of the accommodating IOLs that we learned, at least the study that I was involved in, was now almost 10 years ago, we didn't collapse the capsular bag. And yes, because the phakic lens, our accommodating IOL is very large, it fills the bag completely. And so anterior to posterior is still about 4 millimeters. And so the nice part is we noticed that, number one, by keeping the bag open, there was no PCO ever in any of the patients, ever.
And much less risk of vitreous detachment with
Right. There's no collapse in the capsular bag, so there's no lens tilt. The effective lens position doesn't change. You don't collapse the vitreous. You don't induce a PVD. It's like, that may be the way of the future, is to have new IOLs that we can still go through our tiny incisions, but end up filling the bag a lot more than we do now with our very thin IOLs and then collapsing of the bag.
This will be the ideal, but I mean, do you think is it going to be around anytime soon? That's the issue.
Well, that's the hard part. So impossible to predict, you know. I mean, luckily there are a lot of horses in this race. So there are a lot of companies developing similar type products. I
And
hope
that's
that many of them succeed so we can have more and more options, and we can have, you know, I'd rather have more tools in my toolbox instead of fewer.
I agree.
Which also brings me to the my next thing I was talking about is, you know, you were saying that refractive surgery has really changed or evolved as subspecialty. You know, I talked to Guy Kazarian, who is obviously a big proponent of this in the World College of Refractive Surgery, and it need to evolve into its own particular field. And his analogy was like how you do general surgery, but then you shift a few years to just plastic surgery. And he says refractive surgery may be like that. You do ophthalmology initially, and then you just kind of shift to just purely refractive based because it's totally different. It's not something that we're often taught in our training.
I agree. I think this is important. And there are a lot of concepts that we need to, it's like going back to school, a lot of concepts that you need to brush on. Now, I think always that our residents are getting much better exposure to refractive surgery than what we got so many years.
Yeah.
Because they're following everything. If they go and attend your sessions at the ASRS with cataract, I mean, there's definitely, they have to understand trifocal and extended depth of focus. They have a primer on refractive surgery. They're starting with aberrations. I mean, we heard about aberrations when we were in our fellowship. It was different with the dark ages then. So I think that's definitely evolving. But I still do believe, as you said, that we need a protected time to develop into a better refractive surgeon, and that protected time cannot be but by a fellowship that is purely dedicated for that.
Right. I think we're starting to see those now in the U.S. A few fellowships that are basically purely refractive. They're not cornea fellowships that have a little refractive surgery. They're purely refractive surgery fellowships. Corneal, lenticular, the works.
I agree. I mean, if you want to do cornea, you can do 1 year cornea and 1 year refractive surgery, but by all means, not do 2 years of cornea / refractive, for instance. Okay, or even worse, 1 year of cornea / refractive, because you won't have, of course, you won't have any exposure to both equally.
Yeah, no, that's very, very true. Very true. And then obviously keep learning because I mean, all the stuff you're talking about, you never were taught this 20 years ago. You learned this on your own. Heck, you developed half these things.
Well, I mean, we're fortunate we were there whenever it started and we were part of it. But I always think that the best time when you learn is when you're young for many reasons. It's one of the reasons also is you don't have so much clinical responsibility. You can dedicate some time to really understand the basics. But later when you become a busy surgeon, you don't have much time. So that's why the fellowship is what makes you. Even if you're on a even special interest track or maybe a research track, this interest, you developed it in your fellowship, whether with your mentor or whatever, or whether you forge it yourself. And later is going to be a fine tuning of that track more and more. But it's hard to create a new track, all from scratch, unless you're somebody like Damian Gatinel, who in the middle of his career decides to do a PhD in wavefront technology, and for the mortals, all of us, I think it's important to forge it from the fellowship. And that's why I think fellowship should be really a foundation of your knowledge.
Tell me a little bit about your fellowship. Our podcast goes very wide. 10,000 ophthalmologists may hear this. And especially a lot of our listeners are younger ophthalmologists who may come and apply to your fellowship. But tell me about your fellowship.
Now, I was fortunate to be among great mentors.
The fellowship that you offered.
That I offered. So basically, it's an interesting fellowship because we have 1 year and 2 years fellowship. 1 year is mainly clinical. 2 years is clinical work research. So it's focused on refractive surgery, all kind of refractive surgery, whether it's cornea, lenticular. We have a major part which is therapeutic refractive surgery, teaching cares, total wavefront guided and ocular wavefront and topography guided PRK with cross-linking, performing phakic lenses, again, all type of premium IOL, and then mainly looking at the diagnostic equipments and making sense of it. And this is all what you're going to do the whole year. So basically, you're going to think as a refractive surgeon, you're going to operate and keep thinking about that. And there is a protected time for that. We don't give them anything related to cornea. They can scrub on our DMAX but they don't have to, you know what I mean, follow these patients. This is optional if they want. So, and I made sure that we don't give any cornea assignment for the fellows. This is mainly a refractive surgery fellowship, and they rotate with three attendings, faculty with them, so they get to kind of see everyone how they're doing and how they're thinking. And then, of course, they teach the residents, so also they get to prepare things. And then even if they're doing the 1 year, they will get involved with research. And I really believe that research is so important to kind of develop a mind frame and think about it, because I do believe that a successful research should always answer a question that you have in the clinic. If it does not answer a question that you have and it's nagging on you in the clinic, it's not really worth it, and you will not have passion for it. So I'm against doing clinical trials for a company who tells you, okay, can you do this clinical trial comparing A to B? I don't want that. I want something that I have in the clinic. I keep noticing it. I want to fix it, and I want to run something and improve it. That was the decision for us to look at mitomycin C and PRK, because we really had severe haze when we combined PRK with cross-linking, and we didn't know why. And then we tested the theory, we found the reason, and we shifted. Now we dramatically combine them together. We have no issue, and this served our patients because we are making them better. So for me, the fellow needs to be involved in research, but probably less if it's 1 year versus 2 years. But research is what helps the fellow develop this mind frame and thinking into a problem-oriented way of solving issues.
Well, sounds like a fantastic fellowship. How many fellows a year do you take?
One.
With one.
Yeah, it's either a 1 year or a 2 years, because it's honestly, when we started the fellowship, it's a hard thing, especially when you started, because you have to invest time. It's not something that you just do and then they will learn on their own. It's completely different. It's not cornea surgery here. The cornea surgery, it's they see you operate, they study by themselves, they can do it. But Uday, let me ask you, do you know of a comprehensive book for refractive surgery? No. It reminds me when my father, he wanted to get working on computers. I was still a 25-year-old, and he asked me, okay, can you sit with me and show me how do I start? What do I do? And I started telling him, okay, you can right click here and left. He's like, what is right clicking? What is left clicking? Or double clicking? And I'm like, oh my God, I mean, that's teaching, but he's great now. He's 92, he's doing very well, he's excellent, he's really good at computers. But I just tell you that this is refractive surgery, because if I want to teach the residents, it's very hard to tell them go read books like in cornea. Things are evolving haphazardly, sprawling over a different landscape. They want to understand a little bit of wavefront, a little bit of topography, so many things, and you cannot have a curriculum, easy to start. So it's important that you have to teach that. For every case you do, you have to stop and tell them a little bit, then tell them go read something. You have to guide them. Where in cornea is different. They just read a little bit about DMAC. They see how you're doing it. They'll do well. They see a couple, and then they can do it. Right. So it's different. It's more concepts, and that's why you spend a lot of time. So I think you can't take more than one fellow. If you really want to get that fellow from point A to point B, I think you have to invest in her or in him.
Yeah, and it's a field that's constantly evolved. You can't have a single book about it, because as soon as the book is published, well, there are new things that contradict the book. It keeps changing.
Exactly.
But again, that's that's the fun of it. That's what keeps us entertained. We're lifelong learners, right?
It's so true. This is like chess. Chess. Right now, if you think about the possibility in chess, they tell you the possibility are like all the atoms in the universe, right?
Right.
The universe. I mean, I'm sure at one point it will be solved, but even now with AI, it hasn't been solved. And that's what keeps the game interesting, because you cannot master it already. And that's what's nice in refractive surgery. And ophthalmology in general, but refractive surgery, because it looks so simple, but it's not. Okay, it's more complex.
It definitely is. Wow, that's Shady, I want to thank you. We had an amazing conversation. I learned so much as usual from you. I really appreciate it. If you have any interesting video you want to feature on Cataract Coach, please feel free to send that.
I will. Thank you.
And again, I want to thank you for taking the time, and I want to thank our listeners for tuning in. Remember, every week we got a brand new podcast, #1 podcast in all of ophthalmology. And of course, we still have a new Cataract Coach video every single day. And we're up to almost 2,400 videos.